We will start this lecture on the second lecture. It will be brought by Professor Dr. Wibawa, PhD as PMK consultant. He's my senior colleague. We know each other for quite some times, and he is a specialist in fungal. And of course, he's a professor at Department of Microbiology, a head of the task force at University of Kacamata on One Health, and he's the chair of the Research Ethics Committee, Faculty of Medicine, Public Health and Nursing, University of Kacamata. And what he will bring today is on the One Health in Indonesia, barriers and way forward. So I think the important because it is important because there's challenges we are facing in infectious disease, and also the climate change and how intersector coordination is needed for this in response to the climate change and the increase of emerging disease. So I think we have Professor Dr. Pawat here, and the floor is yours. You have 40 minutes until 11 o'clock. Yeah.
Thank you, Dr. Edwin. Good morning again. So this is my topic, and One Health in Indonesia. I hope it is not it is just a case study because it might be applicable also in another part, maybe in Pakistan or other Myanmar or other countries that is have a almost similar situation with us. Please, next. Yeah. So again, I will introduce about One Health. Yeah. To whom not yet really familiar maybe, but I'm sure that everybody familiar. But to make sure that we have the same page, the One Health is not like other term for insurance. We have health insurance that called as One Health. We have a system that is managed by our Minister of Health. The same terminology, One Health. But we're talking about One Health that is approach. This is approach where there is a collaborative, multi-sectoral and transdisciplinary approach working at it can be local, regional, or global. And then the aim is to integrate between the human health, animal health, and environment health within one scope. So basically, we don't have the pointer. Yeah. Basically, we we will integrate these three sectors. Thank you, Pa Edwin. These three sectors, and we need to do collaboration, we need to do communication, and we need to do coordination. Hopefully, if we have communication, coordination, and collaboration, so the three sectors that is usually have a different aim, different task, different job, different degree, and different KPI, for example, then they will work together to make sure that these three sectors, the health of animal, health of human, and also environment, will be will be one entity that is going to be one package, right? Next. Okay, so I like to bring one example where One Health approach will be suitable and applicable in Indonesia and also in another country maybe. So we the first is about zoonotic and emerging viruses or emerging disease. Previous lecture concentrate in emerging disease, so it is almost similar with this one. But here, why it is important in Indonesia is because there is a direct threat between us, right? Rabies, anthrax, and avian influenza is the what do you call it? It is a classic example where we can apply the One Health approach there. And then another another situation why the zoonotic and emerging viruses is important in Indonesia, because there is a high risk pathogen that is maybe it can be a pandemic situation or pre-pandemic situation because of the close relation between the human and also livestock and also wildlife. And the third is we have a lot of vector-borne disease, right? Why it is important? Because this vector-borne disease somehow it is really what do you call it? It is it can be changed the situation because of the climate change. For example, for this dengue and malaria, it has vectors. The vectors is mosquito, and because of the climate change, global warming, so the habitat of these vectors is not only in the equator area. It can be transmitted to a little bit far further to the subtropical even. So in that case, before maybe the countries or maybe uh, the area where previously doesn't have the mosquito a lot now becoming have mosquito, and then of course the dengue and malaria will be spread very easy because there is a factors. Next, yeah. So uh against why Indonesia? Because another factor is that we have a very huge biodiversity. We have a lot of tropical plant. We have a lot of wild animal, and we have also many insect, for example. So it is because of the reach of this biodiversity, it can be correlate with the possibility that viral pool also there, or bacterial pool, or other microbes or other germ that might be correlate or associated with the plant we have with the animal, wildlife, and also insect other that is possibly one of the sylphatic circulation will be there, right? And then the proximity among human and domestic animal and wildlife because of the human encroachment make people need housing, people need food, right? And we starting to build our housing in the middle of rice field, for example, or we using the wood to plant some rice or other food. So in that case, the deforestation and the change of the landscape will be not evitable, right? So in that case, the proximity between the people and the animal and also the factors and also reservoir will be close enough to make sure there is a spillover among them, right? And then we have proof historically that we have avian influenza in 2006, for example. Rabies still now we have because there are many dogs that is surrounding in the neighborhood, not in Jogja maybe, but in other places. For example, in Bali or in other island that is they are culturally they are allowed to what you call it, to have a dog in their neighborhood or in their house, right? And then next, bisa nggak sih? Bisa nggak ini? Bisa ke sana apa ke sana? Ke sini. Okay. Okay. Yeah. So this is the numbers where we can start to understand why the emerging disease or new pathogen emerged is quite related with the wildlife, because we still now convinced that almost 45% of the emerging viruses, emerging microbes that is affect our health, human health, will be from the wild life spoil over, and also 30% will be from the domestic animal and livestock, and only 25% directly from the air environment or human to human. So in that case, now it is really reasonable if we're thinking about the emerging disease or pandemic preparedness or whatever we can identify our problem, especially in the zoonotic disease, will be related with the animal and also environment. Yeah. So we're talking about the spillover, right? At least we can identify 4 or 5 factors why the spillover can be accelerated by this situation. The first is about habitat deforestation. Yeah, habitat disruption. For example, for the change of the landscape and change of the or maybe forestation, as I mentioned before. So in that case, the wildlife that is usually have a habitat in this wood because we starting to open this land, then the proximity among human and this animal that might have the certain pathogen that is never been identified even, then it is going to be close interact. And then another possibility is that because we need a lot of food, then we starting to do agriculture intensification, right? Agriculture intensification in this picture is about the livestock because livestock is like a genetically similar host, right? That will able to facilitate to the for the pathogen to mutate among them. And then because of the intensification, as I mentioned before, we starting to do the deforestation because we need land to to plant our rice, to plant our food, right? And then another possibility that is accelerate the spillover is because of the global transportation. For example, today we have spillover in this town, and then maybe tomorrow you will have this situation from human to human transmission in another place, maybe in Taiwan or maybe in United States or even further that we cannot imagine before because of the global transportation. And then the next is the contact zones. Now in Indonesia, we have still the wet market where people, um, what do you call it, selling the wildlife to be consumed. In that case, of course, the possibility that human interaction with the wildlife will be increased. And even because they're starting to slaughter, they're starting to consume, then of course the possibility of people get infected from directly from the blood or from the fluid that is excreted by this animal will be increasing. So in that case, the spillover cycle will be accelerated. Yeah. And the disease emergence here, the people becoming sick. It is possibly directly from the wildlife. As I mentioned before, we consume wildlife, we slaughter wildlife, and then of course the excrete and also the blood will be directly contaminate us. But another disease might have another pathway, not only directly from the wild ecosystem to the human, but it can be facilitated with a intermediary amplifier. For example, here with live animal markets, as I mentioned before, and then second is through the intensification of farming or for the livestock. Okay, yeah. So this is our example that we have. This is that is related to the livestock. Previous lecturer saying about the avian influenza, and it was true in 2006. I cannot imagine if there was pandemic in that time, right? Like COVID. Maybe we are not in good condition to be prepared for the pandemic situation. Yeah, the laboratory, the laboratory capability, and then the surveillance, and even the the human resources was not really available in that time. Yeah, but lucky for us in that time, 2006, the avian influenza pandemic was not happen, right? Rabies now we have still. We have Nipah race just before, but we never have in Indonesia. COVID-19, there are million people die in Indonesia and also in other countries. Dengue expansion, dengue infection, we have a lot every year. It's like a annual cycle. We have the dengue. Malaria, we still have malaria, especially in the very east part of Indonesia. We have a lot of malaria cases. So that is why the zoonotic disease will be the first concern, especially that is need for us to apply the One Health, because you know it come from the animal, and the environment will be the buffer of the transmission among the animal to human. Okay, the second example will be the antimicrobial resistance. Is it pandemic? Yes, we call it as a silent pandemic, right? Because we we have this situation that people got infected by the bacteria, fungus, or virus that is already untreatable by the antimicrobial that we have now, right? And then because of that, it is it can be affect many people. It can affect many people, not only the poor. It is also the richest, not only the people that is have low education, but even the high people that have high education, it is possibly got infected by this antimicrobial resistant situation, right? And then now globally we have around 1.2 or almost 1.3 million deaths attributable or associated with a antimicrobial resistant or because they got infected by the bacteria, virus, and also fungus that is already uh, not able to be controlled by our drug, our antimicrobial substance. So why? Yeah, the most important thing is because of the unregulated human misuse, right? That is in my field, of course, human use, and because I work in the hospital, so people understand that many doctors give the antibiotic that sometimes this is not necessary, right? But actually, we have also another situation in the agriculture, right? Though there I put one thing that antibiotic as a growth factors. We are banned already. Government does not allow. We have a regulation that the antibiotic cannot be used as a growth factors. But who knows, right? Yeah, because not like in human, we give the pills using the prescription, right? What about in the agriculture? Because they maybe there's a supplement for the food, for example, or even before there is a discussion about the aquatic aquatic culture for the fish. They just put it in the water, actually, right? So how can we control that one, right? And then the overuse of the or misuse of this antimicrobe will give us situation we call it as selection pressure. Selection pressure means that we are actually unintentionally or intentionally select the microbe that is resistant. Yeah, we kill the susceptible one, but the resistant will be remain, and this remaining unsusceptible microbe will be circulating among us. So the probability that we can get the microbes and we getting ill because of that is only associated with the what? With the resistant one, because the susceptible has already cleared out, right? Okay, next. these are the figure that can be used to understand why the antimicrobial resistance is associated with a situation where it is in animal, environment, and also in hospital. This is three sectors involved, right? If we talking about the antimicrobial resistance, we have to consider about this antibiotic residues. So because we give the antibiotic to the animal or to the human, then the residue will be there, right? For example, I prescribe my patient with antibiotic in the hospital, and then the residue of this antibiotic will be in the wastewater, right? And then the second thing is the antibiotic resistant bacteria itself, because many antibacteria that is already not susceptible to antibiotic in our hospital, and it is infected our patient, and it is also in the infrastructure, right? In the bed, and in the whatever in the hospital, because they can just attach to the wall, for example, or in the floor, for example, and then it is possibly that they can be transmitted to the through the wastewater again to the environment. And the last thing is that antibiotic resistant gene. Why we need to consider this? Because this gene can be transmitted among bacteria, not only from the bacteria that is able to infect human, but it is possibly also transmitted to the to the microbe that is actually not human infectious. It is not sorry, it is not an infectious pathogen for the human, but they go to the wastewater, they go to the water body in our river, for example. Then they're going to meet with a bacteria that might be in the environment, and they transmitted the gene, and then this bacteria becoming have the gene, and then after that the next when they meet yeah when they meet the bacteria, another bacteria, they will transmit again, and after several transmission it can be come back to the human and also in the animal. In that case, of course, these three will be important. I mentioned about hospital. What about in the farm? What about in the aquaculture? The same situation, right? Because we use this antibiotic in hospital, the same thing we use in the farm. The same situation will be happen. Okay, we share the antibiotic resistant bacteria, we share the antibiotic resistant gene, and we have the antibiotic residue among us. Okay, so how can we tackle down this problem if only in the human sector will think, and the animal sector will have a what policy or intervention, right? It should be one health here. Okay. Okay. Yeah. The third threat is about the environmental amplifier. We call it as, for example, we have pollution, right? We have poor chemical. Uh, we have a chemical effluent that is come out from our household or from our industries or our other institution, right? And then go to the river, and then go to the sea, right? And then untreated clinical wastewater, right? We understand that our hospital maybe have the wastewater plant actually, but for the quality assurance, they are not counting about the antibiotic resistant gene. They are not counting about the antibiotic residue, and they are not counting about the antimicrobial resistant agent, because we just check it the bio bio POD itu apa mas? Bio mas POD itu apa POD? Ya, but yeah. He's the expert, all right? Biological oxygen demand, right? That's our indicator in our wastewater plant, right? So actually we missed the three, right? Also in the hospital, also in the farm and other institution. And then the next is about the this one. Because of this situation, can you imagine? This must be rodent and other factor will come, and then it is going to be exaggerate the process of the transmission of the zoonotic disease. Okay, and these are the plastic that we have. We still have plastic there, right? Here. So plastic is always problematic because you can see this. This is the curve where the industry making a plastic good, right? So it is like exponential curve, right? So we are using plastic a lot, actually, right? And then the problem is here, plastic degrade very slow and even cannot be degrade, right? Only 9% of this waste, plastic waste is recycled. And then after that, you can see that almost 80% will be end up in the landfill. So now if the production is increasing and then 80% will be done in the landfill, then you can imagine how many plastic will be accumulated every month, every day, every minute, maybe, right? But if you have this plastic, for example, you have this one, and then somebody just throws it out right there, you can just pick it up, right? And then put in the recycle bin. But the problem is if this becoming microplastic, right? Because it is going to be degraded, right? And then the microplastic is still there. So yeah, we're drinking the microplastic. We eating with the bonus of microplastic, of course, right? And these are the situation that we may have to consider that microplastic and plastic will be correlated with this. Why it is climate change? Why? Because the industries that we use to develop plastic will contribute around 13% to 20% of the carbon dioxide emission. So it can be trigger for the climate change. The second is biodiversity loss. Because what? Because if you have plastic, you have microplastic outside there, then the possibility that there is plant, there is insect, there is a wildlife that is going to be endangered because they got poisoned by the microplastic. The third is the disruption of absorption of carbon dioxide, of course, because of that, right? And then impact to the our health. The human health have directly correlate with the microplastic. The animal health, right? So if you're talking about the animal is our food. Are you agree? Yeah, you are agree, right? We are agree that actually we are the animal is our food, right? So if the amount of this what do you call it, the animal is decreasing, then of course we are going to starving because of that, right? If for example in our sea there are many fish and other animal that is habitat there becoming poisoned by this microplastic, the production of our fish will be decreasing. So how can we give a how can we feed 9 billion people that is living in our earth? So that is another problem. Okay, so now we concentrate about the detection and response. Before when we talking previous lecture talking about what? Talking about the prevention, detection, and response, right? So now we only concentrate between detection the problem because we have already, for example, and then waiting for the response. And these are the problem we have right now. Also in Indonesia, maybe in another country, maybe in the same, right? Government and policy gaps. There are silo among us. the people that is working human sectors are always very dumb to what? To talking with the people that is working in the animal sector. And even between this sector, they cannot talk each other because they actually from another planet. They talking with different language, right? I'm a human. I'm MD. Then I will talking just like I understand everything, right? With a very specific terminology of medical thing. And then of course the people that is working in the environment cannot understand what I mean, right? And vice versa. I cannot understand what people that is deal with the environment and the in the animal because I am not really understand because I never learned about that. Okay, data fragmentation. Of course, we have surveillance in human being. We have surveillance in animal. Do we have way to combine that one? No, sometimes we don't have resource constraint. Yeah, people that is understand to make them the three speak with the same language is really very very rare, right? And another thing is that this resource mean money, financially. Maybe we don't have awareness and culture, awareness about the One Health itself, the culture of somebody just mentioning about the social science, right? Yeah, how can we understand? Right? How can we understand the anthrax situation if we don't know the social setting of this anthrax, the social setting of people having one cow or one sheep in the backyard? It is really true investment for them, right? How can we say, you get anthrax, please stamp out, just kill it? No, not like that, right? Because it is investment for them. Eh? It is their what? Their money, actually, right? And then implementation weakness, of course, that one. Yeah. So the high risk environment, as I mentioned before, at least we have three example, and then amplified by the fragmented data and siloed governance, meaning uncontrolled outbreaks. So now, where are we now? Right? We have this problem, and if we have also the same thing, this problem, then it is going to be doubled or even triple or tenfold or even hundredfold after that. Uncontrolled outbreaks, right? Okay, so these are the paradigm shift the matrix. This is fragmented. Can be applied for the surveillance, governance, AMR management, and also response. And here is the unified. So you can just what do you call it? It's just dibandingkan. You can just compare it, right? You guys can compare it. If it is unified, then the surveillance will be real time and integrated, and here it will be segmented, for example. Okay, and then actually, actually, all of us, not in Indonesia only, another country maybe have the same asset. We have digital growth. We have digital technology because everybody now have a smartphone. Now people have starting with this one. These are what? AI, right? We're using AI. Even we are now, if you go from this campus to some restaurant, for example, we are not thinking anymore because we're using the AI again, right? Yeah. So we have digital. What do you? This is a capital, right? And then we have academic strength like you, right? Like all of you, the academic strength. You have the power of your intelligence and also understanding about the One Health, right? And then we need to learn from the developed nation also that they have what do you call it? They are not they just starting earlier with us, so it is possible for us to just catch them, right? To catch them, and if we see the situation, I think we need to become the first because we have the problem there. We have zoonotic disease, we have AMR, we have the pollution and what other problem that can be suitable for the One Health. Okay, this is the situation. If we have surveillance, right? We have surveillance, right? Surveillance for the problem we have. There is a real-time data collection. Of course, we have. Every sector have that. We have sentinel surveillance in a very high risk area. For example, the Fed has been noticed that certain districts have anthrax, have certain districts have avian influenza, right? But the system is not integrated. Yeah, we need to cross-sector information sharing. In that case, we're going to have a good early warning system if we can combine that one, right? Yeah, this is the situation if we are still in a silo, and this is the situation if you have integrated surveillance metrics. The information flow, the systematic visibility, and operational stance will be quite different. Everybody must understand and convince that the integrated will be better comparing with the sectoral silo, right? So this one, for example, the human sector, animal sector, environment sector, they're starting to collecting the data. The syndromic surveillance, for example, we have people that have a dengue virus infection, for example. And then here, maybe the animal sector starting uh, 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 to to collect the livestock mortality rate and other thing. We have here anthrax, for example, and then also in the environment, they starting to collect that, and then they combining, and then maybe they will able to predict what will happen. Yeah, for example, in the human, right? In the human, the doctors starting to reporting some unidentified illness with a with a with a fever, for example. And then from the animal sectors, they saying starting to reporting that some animal also have a similar situation, the animal starting to die earlier, right? And then the environment sector is reporting that this area has deforestation. So when the interaction with the people that get sick because of have a fever might be correlate with the die animal, right? So I'm sure that if we have that system combined, then the early warning system will be work much more better comparing if it is not combined. Yeah, maybe some of you in Indonesia have ever heard about it. SISE is a System Informasi Zone System Emerging Infectious Disease. This is the system that is bring by the coordinator minister. So they are coordinating the three Minister of Health, Minister of Agriculture, and Minister of Environment. Previous lecturer just mentioned about this one, ISICNAS, that is uh, in the animal sector, and these are the human sector, and these are in the uh, forestry and environment. They reporting about the wildlife disease. So using this platform, this size platform, they can combine the three, right? Yeah, it is. It was only 2023 start. I hope it is work, right? But I heard from Prof. Vishnu, he's expert wildlife. He's saying that these are very weak. The most point is here because not many people working in the wildlife. Very only few FedMed working in there. So how can we expect it that there will be a report from the wildlife? Yeah. But still, the system is there. Now we can just push to use it, right? Okay, and then how do we move forward about it? So one thing we have to consider becoming two point, right? So first is how to leverage institutional capacity, and the second is to do the community integration. One of the student just asking about the role of the community, right? So here is, yeah, we need to change the behavior, like thinking in silos, thinking that the health of people is not related with the animal, for example. We have to change that. And then stakeholder involvement, right? So every sector they have their own stakeholder in front in the field, right? Maybe if in medical in human they have if we call it as apa kader, yeah, people that is in the community that working in the human health, and maybe we can have the same thing in the animal health, right? And then here in the governance we trying to allow apa to increase the capability of the workforce, like us for example. We need to leverage our infrastructure including digital platform, and also make sure the sustainability not only not only 1 or 2 years program, but it's going to be apa, uh, continued until whatever, apa, berkesinambungan itu apa bahasanya?
Continuous.
Continuous. Yeah, sorry, I have a struggle in bahasa Inggris. Yeah, and then this is the public awareness. We need to increase the awareness among our people about the wet market. It is related with the zoonotic disease, about self medication belief. I think in other country also it's the same thing, right? Sometimes we go to the drugstore and asking for antibiotic, for example, and when these people was asked why you need antibiotic, because I have a headache, because I have a toothache, for example. Yeah. So we need to, thank you, we need to train them, right? Zoonotic disease, the same, right? Okay. So at least there are 4 steps that we can do, right? First, we need to align between the problem between among the three, and then integrate the surveillance, integrate the capacity, integrate the approach, for example, and then increasing the capacity, and then make sure people understand, then make sure people will join how to align and integrate the 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 the, the force, right, in animal or in human, and also in environment. And I just want to share that we has just newly published a book. This is this many chapter inside this book, and then the writer is among us, the member of One Health Task Force in UGM, and also student, and also other practitioner. Okay, maybe you can just access that one. Thank you very much. Yeah.
Thank you, Prof. But you still wait at the front. Now we have around 20 minutes for question and answer. 20, yeah, Prof. So anyone, first of all, in this room, yeah, over there. Look over there. State your name and where you come from.
Thank you, Prof. Tri, for the amazing material for us. My name is Risna. I'm from International Health Program, WHO TDR, and I want to ask about if we have a very limited resource, what do you think need to be do first, the institutional capacity building or the community capacity? Thank you.
Okay, that is a very intriguing question. Which one? The community or the government, that is including regulation, right? I think we cannot choose. right? We have to do both in parallel, because if we have and we have a regulation, for example, the implementation will involving the community. Like I just mentioned that we have regulation, very strict regulation about the use of antibiotic in the for the growth promoter, but still the problem is people starting to using that as a growth promoter. We have a program for we call it as antimicrobial stewardship in our hospital, in our clinic, but still the doctor is still using this antibiotic over overuse, because they believe that they need to do that, otherwise the people die, for example. So we cannot choose. You have to working together in both sides. Yep. Very limited resources, like tricky, right? Yeah. You can say that limited resource, but actually you have, for example, as I mentioned before, we have digital literacy and we have expert like all of you here. Why don't we just move together to do that, right? To involving the community, you just take your smartphone, you have your podcast, and you can just make it viral, right? Saying that please do not use antibiotic unless you are needed, for example. Right? It is very easy for you, right? And you don't need to wait the government to have the regulation about it. Thanks. Yeah.
Yeah, next question from this side.
Okay, thank you so much for the opportunity, Pak. So my name is Jonisa. I'm actually coming as a researcher from I help University of Kent for research in one of it is zoonotic disease, and I think this is probably more of a hope compared to questions. In this the whole in this course, I hope we discuss the challenge with local community and culture more, because in one of our research, we are trying to see the relationship between hunting and wildlife consumption in Bornean communities, especially the Dayak, which is a very big part of their culture, and also rituals. So, and that's definitely, as we all know, been discussed since this morning, that it's a main threat, yeah, consumption of wildlife. But then how do we see it from cultural perspective? Oh, and actually I came from environmental anthropology backgrounds because of all this. I'm really interested to see One Health integration more with social scientists in the future.
Yep. Yeah. Thank you. It is maybe it is hope or comment, right?
Not comment, yeah, just a hope that we will discuss it more throughout this course, I guess, because cultural, not just in a Bornean community, yeah, but everywhere. I think it's very difficult to disengage from eating wildlife or like hunting practices, especially for communities live very closely around forest or wildlife.
Yeah, it is true, right? So why it need multidisciplinary is because, like one example, we have a seminar, we have a discussion before about the cat lover. There are many cats in this campus, right? One of in the human point of view, medical doctors they are saying that this possibly source of the zoonotic disease, right? And also from the vet, the same thing. They're saying that yeah, please control the number of the cat in them. But when we asking for the social scientists saying that please remember this cat might be stress relief for the students. Some of the students becoming lonely because they are far away from their family, right? And then they starting to just cuddling the cat, right, like a pet. And then a lot of sudden another student have the same situation, and they able to communicate, and they have each other because they are loving the cat, for example. So that is the one example that the social scientist is also part of this One Health situation. Another example, we have anthrax in Yogyakarta. As I mentioned before, anthrax is related with the with it, the culture where people will consume the sheep or the cow that is becoming sick. Before it was die, they starting to slaughter, and then they consume the beef and the meat, and then they are distributing to the neighborhood, and the neighborhoods also buying the cheap beef, cheap meat, because in the social anthropology point of view, maybe people want to what do you want to help the person that lost their cow, because it is worth around 25 million rupiahs, right? So at least they can just donate it. That's the first. Then second is that for the people that is in the suburban area, maybe on the rural area, consuming beef not every day. And then now there is a meat that is very cheap. So they need to buy that one, right? So this is cultural thing, right? This is social thing. Then you cannot say then, please do not eat that one. Please do not do that. No, it is not the way we thinking and the way we act, because we need the social science expert to help them to understand that there is a situation where we are in the risk of the becoming transmitted Bacillus anthracis among the people and also the cow that is sick, right? Yeah, thank you to rise about the social science here.
Should we have another question? Oh, there's two.
Yep.
Who raised the hand first? I to this one. Okay.
Thank you. Good morning, everyone. My name is Rani. I'm from Indonesia. Prof. Tri, I want to ask, in our primary healthcare, like puskesmas or primary clinic, laboratory investigation or laboratory testing to confirm bacterial infections like CBC or bacterial culture are rarely performed due to cost effective and accessibility. And my question is, how can clinicians, especially general practitioners, can prescribe antibiotic rationally to prevent antimicrobial resistance due to this circumstance? Thank you.
Ya, Pak Edwin bisa membantu jawab saya.
Thank you, Prof. Tri, for your right. So we have to look not just by one side that this person is sick and we give antibiotics, but we have to see whether this sick person is infected by bacteria, and then we have to identify what bacteria is infecting this person. For example, pulmonary disease, pneumonia. So we have to check this person by checking the sputum specimen. And then we collect and we identify whether this sputum is indeed infected by the bacteria what we are searching for, example, Klebsiella pneumoniae. And then we put this into a machine and identify which antibiotic is resistant and which antibiotic is still sensitive. By there, we give this result to the clinician, and then this clinician will then decide which antibiotic is required for the patient according to the result we have given them. Is that right, Prof. Tri?
Thank you, doctor.
The problem is in the primary healthcare.
The
right?
primary healthcare
For
If there's not available in primary healthcare, we do have this system where we can send this specimen to a hospital where it has the capacity to identify and detect this bacteria. I think that's the only answer I can get.
Thank
Yeah.
you, doctor.
Yeah, the referral system is the answer maybe. And then actually in our system in Indonesia, we have a clinical laboratory in every province. We call it as Balai PPLK. Yeah. PPLK designed actually to serve that situation. So the from the primary health care, you should not refer to the private, but you should refer to this laboratory. By design like that. But yeah, this is ways just to refer it to the referral hospital maybe. Okay.
Thank you, Prof. Tri.
Ya itu masih ada satu lagi, silakan.
One more from this group.
Thank you. Good morning. My name is Ahmad Solihin. You can call me Asol. I'm from Jakarta. I have question. In lab, especially biotechnology lab or microbiology lab, when we culture bacteria, sometimes we add antibiotic on media. The question is, they use antibiotics in labs for research or academics. Is it drive to AMR2?
Yeah, thank you. That is that's a good question, right? So sometimes the antibiotic we use is not only for the curative approach, right? Curative purpose. And of course, true. In our lab, there is need also for antibiotic. But you need to understand that actually every time we use antibiotic, every time we make the selection pressure. So make sure that if you use that wisely, you use that. Otherwise, it is going to be part of the selection pressure. Yeah, it is true. So that in that case, sometimes we use the antibiotic that is not really used in the clinic. For example, for the antibiotic for identification of the microbe, we use the antibiotic that is not used in the curative approach. Like for example, we use the bacitracin, optokin, or other thing, right? Because aside because they have the specific characteristics, so able to us to help us to identify, but they are also not in use in the clinical setting, right? Yeah. Yep.
Okay, thank you. And one from the online. Oh, this one more. Oh, so we still have 10 minutes.
Hi, everyone. Sorry if I ask question again. So, you mentioned before, Prof. Tri, about the diagnosing tools and metric on the slide. So, you also mentioned a couple of times about the prevention, the importance of prevention in One Health. So I wonder if in the previous slide there is a diagnostic tools, which is to diagnose the situation, the condition by, for example, the metrics. One of the metric is the admission, the hospital admission, and the number of illness or disease. But is it possible, and would it be beneficial if we develop forecast tools rather than just a diagnostic tools? Because we already knew that I'm sure that we already map out like the high potency area. It depends, considering like different culture, like the previous questions already mentioned, like the urban rural situation will have different potential threats. So maybe is it possible for us to develop forecast tools to map out for prevention? So not only diagnosing when it's maybe already a little bit too late since the outbreak is progressing rapidly.
Yep. Okay, thank you. That is good idea, and it is already applied actually. For example, we have many people that is working in epidemiology. They able to do the mathematical modeling to forecast, right? For example, if you see some of the reference, they always saying that in 2050 it is going to be 10 million people dead. associated with the AMR if we don't have any clue to tackle down the problem now, for example. It is mathematical model. Yeah. But when we saying mathematical model, so we still have we still need actual data. We need data to be analyzed, right? And then of course we can predict if we have the data. Yeah, it is true. I'm agree with you that instead of using only like a reactive one, right? Oh, there is a dengue now. Oh, there is a many laboratory positive for dengue today, misalnya. So it is going to be very late. But actually, people that is working in the, for example, district health, dinas kesehatan itu apa sih? Health district agency, usually they are working to predict that one already using the last year's, 2 years or 3 years data, and then they perform mathematical model, and then they able to predict the possibility that the dengue, for example, we know now the dengue have a 5-year cycle, for example. Yeah, it is because they count it from the actual laboratory data.
Yeah, but dengue is not only from the technical. Thank you. From the technical aspect, but also maybe we can also map out why this disease will happen, particularly in this area, because of different economical contexts, cultural context. So not only like forecasting, there might be like this disease in 2027, for example, in this country, but different local area, they have very different potential disease and threat, something like that, but more specifically, so not like general prediction, something like that with the mathematical model. That's actually not what I mean.
Yeah, it is true. Yeah, if we do able to do that, then it is good. But just want to add some information, like we have several area with the hotspot of anthrax, for example. We have Boyolali, Salatiga, and other, and then of course the sentinel surveillance will be concentrated in that area for the anthrax, but not Jogja. Maybe Jogja have another disease to be scrutinized every time, right? To predict that one. It is true. Yeah. And yeah, we call it as sentinel hotspot surveillance, that one. Yeah. I think it is good to be discussed in this class, maybe. And maybe in there will be Pak Anis, yeah, that is going to teach us how to predict that one using the data from the epidemiology thing. Yeah.
Is it possible for one more question, or I think that we have short of time. We have still one lecture. I mean, one session. So I'm sorry. Thank you very much, Prof. Tri, for this insightful information about not just the disease, but how we actually need other intersectoral communication and information to response to the One Health situation.
Thank you very much.
Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh.